Okay, thank you again. And now it's my great pleasure to introduce the second speaker of the day, Professor Maurizio Corbetta. And I even need a much longer paper for him. So he's currently Chair of Neurology, Director of the Neurology Unit, and Professor of Neurology at the University of Padua here in Italy. And he's also Professor of Neurology, Radiology, and Neuroscience at the Washington University, St. Louis. He got his MD already in 1985, which you would not expect when you look at him. At that time, I remember some teachers still try hard to teach me the basics of biology while he already got his MD. Very impressive. Then he did his residency in Verona, another very beautiful Italian city. It's a good place to visit. And then he did a fellowship in neuroimaging at the Barnes Hospital, Washington University. And this is where his time at the Washington University starts. So he stood there for several years and did many things. From 1996 onwards, he was assistant professor in neurology, assistant professor in radiology, assistant professor of neurobiology, and became then associate professor in neurology. Since 2005, he is professor of neurology, radiology, and neuroscience in Washington. And since 2015, he is professor of neurology and the chair of neurology at the University of Padua. I did a little Google Scholar search, actually, to see what he has published already, and I was pretty shocked. He has a lot of papers, and 14 of them are even cited more than 1,000 times. And there's even one of the paper which is close to being cited 10,000 times, and this was really amazing. So figuring out what is his big field of expertise is a bit difficult. He did really a lot of different things, but I have the feeling, at least from my little investigation, that stroke was and still is a major topic of his scientific work. And this is also part of his presentation. It's about stroke imaging. I don't have the title now here to see, but Maurizio will tell you everything in detail. Thank you.
Okay, thank you very much. Getting old is not a badge of honor. I mean, it's just life. Okay, so I'm not going to discuss 7 Tesla data because unfortunately I do not have a 7 Tesla Siemens scanner. But what I'm going to try to tell you is a much more, I guess, clinical story, which may be applied to stroke, but also can be applied to pretty much any clinical population that you might want to study. And this is based on maybe work that we've been doing over the last 10 years, based on NIH funding. Actually, for the last 15, 20 years, we've been working on this topic. And so we have kind of went through the different phases of studying disease, first with PET scanning, and then task fMRI, and more recently, resting state and connectivity. So this is kind of, I guess, a cookbook, you might say, for how to study disease population using functional imaging and structural imaging methods. So I first want to give you, I'm not sure the movie is going to work. Let's see if here's, can I have the first slide? I'm clicking. Oh, is this one? Oh, I'm sorry. Yeah. Okay, I'm going to give you a flavor of what is stroke. So we have a patient here who has a lesion in the left frontal lobe, and he has an aphasia.
All your children are grown, right? How many children do you have?
I think you need to maybe increase the volume.
Right? Right. Now let's count it out.
1, 2, 3, 4.
Nice, nice. Well, since you did 4 so well, let's go for broke. Let's go up to 20.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 1,
Okay.
So it's pretty amazing because, of course, he has this striking impairment of speech, and yet when you put him in a slightly different condition, which is counting or even singing, he can actually do that. But then as soon as he goes back to a more propositional speech, like when he gets to 11 and now is working memory or is not familiar anymore, then he's having trouble. So we still don't know what's going on in this brain, in these patients, these kinds of patients that can do that. Were you able to click, advance? Oh, here it is. But for many years, we kind of had this idea that you have basically regions in the brain. So this is a patient that had a lesion in the left frontal lobe that had particularly deficits with one big function like language or speech. Okay, then of course, the last 30 years or so, we learned that there are nodes, different regions are connected. And so we went to this idea of attentional network, language network. So we got into this through task fMRI, this idea that now you have this network of regions. And of course, a region here would also cause some problem upstream and downstream. Of course, this idea, what is called diaschisis, is not a new idea. It traces back to 1904. Von Monaco first proposed on theoretical grounds that there should be some distant effects, remote physiological effects. Now, more recently, however, we kind of have come to this different understanding of these networks. The key here is not anymore that you have neurons that are highly specialized for a particular function, but what matters, as pretty much everybody would say at this conference, is the connectivity. That is how a particular unit, region of the brain, or neurons are actually connected, as we heard from Lars in his last talk. And of course, the functional properties of a particular region, then it will depend on the combination of input and output. It's not just that there are specialized neurons, but it's just the input and output patterns that matters. And so if you have now a situation like the one that I'm identifying, they told me that if I use Keynote, one possible curse would be the delay in showing the picture. So when you have a lesion now, of course, that lesion is going to inactivate, cause trouble, functional, physiological problem in other nodes, and those nodes will reflect a combination of different functions. So you may not expect a single disorder in population of patients, but you might expect correlational deficits. Because, of course, the lesion is going to knock off not just a particular language system, but is also going to spread out in other cognitive domains. So this is one. So the first, I think, lesson, I guess, that we need a framework, a theoretical framework to think about these results. We cannot just blindly compare, say, schizophrenics to control without a theory, because, of course, the data is so rich that it's very difficult to understand. So I think a theoretical frame is going to be really key for understanding some of these deficits. All right, so in order to understand within this framework, to see whether there are correlates, network correlate of lesions, we've been performing for the last 8 years this study, which is a simple study conceptually. We take people with stroke, okay? Anybody that has a stroke is a candidate for the study. It doesn't matter whether they have language, memory, motor, anybody. And then we give them a very robust behavioral battery. Okay, I'm going to mention that again. And then we give a structural imaging assessment, DTI, perfusion with ASL, as well as 35 minutes of resting state. And the second point, of course, is to have a good experimental design, right? And then you need, by these days, you need lots of patients. Studies with 20, 30, 40 patients, unfortunately, cannot be trusted as much as study in which you have hundreds of patients. And this is because a lot of the data require multivariate treatment, and therefore you do need that kind of numbers to infer something about the behavioral deficits that you might see. And the design that we selected is a longitudinal design. Of course, in stroke, a longitudinal design makes sense because you want to study not just the subacute deficits, but you also want to learn what's going on in time. And of course, when you select time points in time, you have to decide which time points you select, and that's a big decision. So we decided 3 months and 12 months, because 3 months, most of the acute recovery has occurred. In fact, most patients are at baseline by 3 months. And then some of the cognitive function in the literature were said to kind of mature and recover more slowly, and so we had a 12-month time point. Now, of course, you can see from the yellow table that in order to do this study with so many scanning sessions, each scanning session may last between an hour and an hour and a half, and we have a 2-hour behavioral battery. There was a lot of attrition. Out of 6,000 charts that were reviewed at the acute stage, as soon as the patient were hitting the stroke unit, about 1,200 met criteria for the study, and of those, we were able to get only 10%. So another concern is that your limited sample, and always going to be a limited sample, need to fit the clinical population. So you do need to control epidemiology risk, demographics, socioeconomic. All of this needs to be matched ideally with a much larger population that you have in your database, but you're not able to scan. So your clinical population that you're scanning should look like a much larger reference population. And so in this paper, we do have all sorts of control on hypertension, diabetes, cardioembolic risk, and so forth. All right. This third recipe, the third element in this kinds of study is behavior. Again, I think in cognitive neuroscience for the last 20 years, when we're doing PET scanning, given we were giving radiation, we might need 3 months of psychophysics before someone would get a PET scan. These days, it's so easy to get resting state that basically we're not really doing very good behavior anymore. And I think that's a problem. You probably heard this morning Danny Bassett, and I think she's also arguing that we need to study behavior more intensely with more specific tools. So we really need to combine, rather than localizing psychological function, which is by now kind of passé, we know that the brain cannot be just an embodiment of psychological function. We do need really to use behavior to characterize people in a highly sophisticated way, using time-moving behavior, multivariate classification, principal component, clustering, all the things that we do on imaging data, we also need to do on behavioral data. And I think that's key. We can now study depression and control subjects just based on imaging and one questionnaire that is going to last 15 minutes because, of course, the behavioral sophistication that we get is very low. So in this battery, again, there is a trade-off. We spend about 2 hours, 42 tasks, 7 domains, and we really try to get as much data as possible to do what? To describe the phenotype, the behavioral phenotypes that we're trying to image. And when you do that, I'm a neurologist, so I teach people how to localize lesions in the brain based on their behavior, and every patient is different. Well, it turns out that at the population level, there are actually 3 numbers, 3 tests that I can give to my patients, and I can account for 70% of variance, both acutely and chronically. Now, that is good news because these are very robust phenotypes that you can use then to image, diagnose, study outcome, do neuromodulation. Those are the phenotypes at the population level. Now, if you have a single behavioral battery, of course, and that's what your covariate for your imaging data, well, that is a problem, I think, because you're not really capturing the phenotype. So these are the 3 phenotypes that we discussed, that we found. One is kind of a cognitive language, verbal memory, spatial memory phenotype. These are principal component of deficits. One is a right body motor attention shifting phenotype, and one is a spatial memory, left body motor, neglect, spatial attention, arousal phenotype. And of course, again, these are simplification of a much richer behavior that we could not really capture, but nonetheless, I was happy to get this kind of description of this behavior. The other thing, of course, then we use the lesions and we try to see where are the deficits in stroke. Again, stroke is, if you look at Google, you say stroke, pops up a picture. There is a picture of a cortical region that has been infarcted. That's kind of the gestalt that we have. Stroke is a cortical problem. In fact, stroke is a subcortical problem. In fact, most of the strokes are occurring in the white matter and in the basal ganglia. And this now we have replicated these results in Padova with a new cohort of stroke subjects. And so this is important because it's telling us that these lesions are actually disconnecting the cortex, and therefore are the functional disconnection of the cortex the main problem in stroke. So stroke, in a way, is like multiple sclerosis, is a white matter disease, it's not a cortical disease. But of course, in segmenting lesion, you can run into all sorts of problems. In standardized lesion, you can also have problems. So for instance, we had trouble between a volume normalization and a surface normalization, a linear surface normalization versus a nonlinear surface, and we settle on a nonlinear surface normalization that we think is the most accurate. When you then look at the effects of the segmentation in free surfer, when you have a lesion, then of course you have major distortion both in the cortical structures as well as in the functional parcellation. And so tricks need to be made here to accommodate. So one trick is, for instance, to expand basically your surface manually. Okay, that's not particularly accurate or objective. Another way to basically flip the brain on the other side. And the third strategy is to use an atlas to basically correct for those deformations. So those are all things that you can do. None of them is perfect, but nonetheless kind of solves this problem when you have these big lesions, or if you have big atrophy, for instance, in your Alzheimer's patients. All right, so now we're ready to look at functional connectivity. We have lesions in the subcortical white matter. We got 30 minutes of resting state. We can do functional connectivity, and we can ask the question, what is predicting behavior? Is behavior predicted by lesion, or is behavior predicted by function? Okay? And in order to do that, of course, we also have to be concerned about artifacts that are coming out in stroke, but also in other disease with functional connectivity. One source of artifact is what is called hemodynamic lags. In areas that have abnormal neurovascular coupling, you will have delayed bold responses. And these delayed bold responses, for instance, can be seen here. And this is an area in which we have computed the lag between each voxel in the brain as compared either to the global signal or to the homolog region on the other side. This is the lesion here in the occipital cortex, a very tiny lesion that is causing just a tiny quadrantanopsia and nothing else. But you see here this huge area of lag in the homotopic PCA distribution that is basically affecting all your functional connectivity estimates. And when you look at lags, the distribution of homotopic lags versus the number of patients, you see that most patients has less than 1 second lag, which is compatible with the MRI signal. But now you have about at the acute stage between 20 to 30% of patients that will have significant lags. So lags needs to be measured and needs to be corrected for if you want to have more accurate estimation of connectivity. Another problem, of course, something that has been beat over the head for many, many years now, is head motion. We want to compute head motion in our control population and in our patients. And here, for instance, we see that head motion increases steadily as we are running more scans. At the same time, the amount of data that we're retaining also drops as we're retaining more scans. But this is a trade-off between having more head motion as you're scanning more and having more accurate estimation of functional connectivity. So for instance, here you can see your estimation of homolateral connectivity in the dorsal attention network increases steadily up to about 3 to 4 runs, and then plateaus. 15 minutes has been shown to be about the amount of scanning that you need to do to get accurate estimates of functional connectivity. And the same can be seen here, although the increase here is more monotonic. Okay. Okay, so at the end of all this exercise for each patient, we should have a QC. And so see, these are some of the QC that we do. We look at the T1, we look at the accuracy of the free surface segmentation, the accuracy of the anatomical parcellation or the functional parcellation. Then we look at the lag map, we correct for the lag map. And finally, we fix the cortical connectivity to make sure that with partial volume correction or distortion due to pulling the brain one way or the other, now your functional connectivity does not end up in the cortex. With all of this, at this point, we're ready to do correlation with behavior. Now, of course, lesion symptom mapping for the last 20 years or so, have been doing correlation for behavior, but I think the emphasis has been on finding significant association between a particular pattern and a particular behavior. What it really matters clinically, and I think this should be the new gold standard, is how much variance are you predicting of that behavior based on your measurements. So variance accounted for should be, in my view, the new gold standard for doing any kind of clinical study. And so, for instance, we can do a machine learning model in which we feed the lesion information, the location, the volume, and then we feed the functional connectivity. And then we develop one form of statistical analysis, in this case is ridge regression, in which we try to predict the behavioral scores or the change in behavioral scores over time as function of this information. And this is what we have done. And of course, you can visualize this data in a variety of different ways. So this is, for instance, a multitask learning model that predicts all the deficits. It's asking what are the connections that are predicting all the deficits in stroke. And you see here, for instance, that the prediction is about 30%. And you see that the connection they're predicting is all the deficits across all the domains is the disruption of interhemispheric synchronization. This is a very low-dimensional phenotype that then you can visualize in terms of the kind of edges that are affected, the kind of nectars that are affected, and then you can get map on the cortical surface that will show you the edges, the areas, the parcels in which you get most of those abnormalities. So let's look at now what happens when we try to predict domain by domain, and let's see if we can learn anything about in this exercise. So one thing that we learn is that the lesion information actually accounts fairly well for the sensory motor deficits, visual deficits, and motor deficits, while the functional connectivity does not account for as much. First, I'd like you to see that the amount of variance accounted for is fairly high, between 50 to 60% of the behavioral score. When we get to language, now both functional connectivity and structural lesion seems to be accounted for significant amount of variance. Now, in contrast, when we go and try to look at predict cognitive deficits, things like visual neglect, visual memory deficit, verbal memory deficits, you see now that the prediction for functional connectivity is much higher than the prediction for lesions, and this is particularly true for memory. There is no way to tell whether someone has a memory deficit just looking at where is the lesion in the brain, okay, except perhaps the hippocampus, which we're not sampling very well, but thalamus, parietal, prefrontal, white matter, we cannot really say whether someone has a memory deficit, but the functional connectivity phenotype can actually give relatively good prediction of memory deficit, like 40% of the variance can be accounted for memory deficit looking at functional connectivity. So, in summary, I think what I tried to show you is that lesion location accounts for behavioral variance, especially for motor and visual deficits, but the mapping between lesion and behavior is not simple. Low-dimensional FC changes account for large amounts of variability, especially for cognitive deficits. And then the difference in prediction of lesion versus FC may reflect the normal organization of brain networks. Particularly, motor deficit and visual deficits are sitting in the periphery of the whole brain networks, and they're strongly connected with the periphery, the geniculocalcarine tract on the one hand and the corticospinal tract on the other. And I think this is why that damage to this critical white matter pathway explain why the lesions are explaining so much variance. On the other hand, lesions in the center of the network, in more cognitive network like the frontoparietal, the default, the dorsal attention, the language network, can be much better accounted by functional connectivity abnormality. So if I may, another 3 minutes? Okay. So as you can see then from this data, of course, it's a lot of work. I think there is also a lot of rewards in studying for many years a single population where you can really try to infer something. One of the most interesting and exciting things about this data set is that these low-dimensional functional connectivity abnormalities that account for a lot of variance will have, in my view, low-dimensional electrical correlates. And I think if we can find and demonstrate that there are low-dimensional electrical correlates, that could be data or input into closed-loop system for neurostimulation that could then be interface with rehabilitation and virtual reality and other things to really try to fix post-stroke deficit, which remains a huge problem despite advances in acute care. Now, the last few years, however, and this is to conclude, have seen an explosion of what people call indirect ways of assessing functional connectivity abnormalities. In a way, if you don't have the patient to go through patients, you might decide to take a shortcut, and maybe the shortcut is going to work. So there's been a lot of work on taking structural lesions, embedding them into atlases, 1,000, for instance, functional connectomes, or 1,000 structural connectomes, and then derive metrics of structural and functional connectivity abnormalities that you can use then to predict behavioral deficits. And of course, this has got a lot of attention. So for instance, there is a New England article that was just published last year on this, as if now we can really do all of this basically on lesion, on structural information only, and these atlases. And so, of course, the way it works, you take a lesion, you embed it into the atlas, you create a region of interest from the lesion, you compute a functional connectome on 1,000 subjects, you take another lesion, you compute the 1,000 connectome in another subject, and so forth, and you do an average, and this is the functional connectivity abnormalities that are associated with those lesions. Similarly, you can do the same effect with structural connectivity. If you have a lesion, you segment your lesion, you embed it, say in the Harvard DTI connectome atlas, and now you extract individual predictions of structural disconnection, and across subjects, then you can generate a group map. So in our data set, we were in the unique opportunity to basically have the indirect disconnection and the direct functional disconnection and try to compare the two to see whether these methods are actually working and how well they're working. So we developed, and this is a poster that is up today, Alessandro Salvalaggio et al., three different inputs: lesion maps, disconnectome maps, and functional disconnectome maps into a huge PCA for data reduction, and then in a ridge regression to predict our behavioral deficits on the same patient than the stroke cohort. And now you get a prediction out that is showing the prediction versus the actual data, and this is a pretty good prediction in this case, versus the weights. This is, for instance, the lesion weights that are predicting a particular behavior. So I'm going to show you two examples, and then I'll close. The first one is the prediction for right motor deficits on 51 subjects. These are all patients that have hemiplegia, severe hemiparesis of the right side. And the lesion prediction weights, of course, get corticospinal tract on the right side of the brain. On the left side of the brain. This is flipped. And we got a prediction of about 37%, with 26 components accounting for 95% of the PCA components. Okay, so quite a few components, but 37% of variability accounted for. The structural disconnection shows more. It shows disconnection of the supplementary motor area, shows disconnection of both motor cortices. Remember that in our data we see functional disconnection interhemispherically, and now the variance accounted for is 38% with 18 components. The functional disconnection also shows plausible maps in the basal ganglia and in the motor system, but the prediction is much lower, only 12%. And the number of components is only 5 components. Now this is important. There is a huge data reduction. Irrespective of where you place the lesion in the brain, you end up with a very small number of functional components, which I think explain why this data is not doing a good job in predicting behavior. Let's look at language now, and this is my last data slide. 116 patients with language abnormality. The lesion, you got a beautiful map of perisylvian cortex being damaged, accounting for 48% of the variance with 58 components. The structural disconnection also does a good job with 40% of the variance. The functional disconnection also produces very beautiful maps of the language system on the left side, both at the level of Wernicke's regions and Broca's area, but the variance accounted for is only 6%. So I think this is a warning, I think, that we cannot really use these atlases to predict behavior, just use base lesion information when the behavior is based on estimation of variance. All right, so I'll close there, and I'll thank my St. Louis team and my Padova new team on the stroke project. Thank you very much.